Um, Hello, everyone, and welcome to Preventing Suicide in the Construction Industry. I am Jessica Bunting, Research to Practice Director at CPWR, the Center for Construction Research and Training. In addition to hosting CPWR's webinars as the R2P Director, I'm also here in a different capacity today, and that's as a new member of the Board of Trustees of the Construction Industry Alliance for Suicide Prevention, or CIASP. So I'll be kicking things off with some brief background on the issue, and then I'll hand it over to the rest of our panel. And today I am very excited to be joined by John Gull, Worker Wellness Director at Missouri Works Initiative of the Missouri AFL-CIO, Karina Lorick, Area Director at OSHA's Kansas City Area Office, and Christopher Rodman, CPWR's Opioid Projects Coordinator. So thank you all for joining me as well. I'm going to start out my portion today just with a slide on where you can reach out or guide others to reach out. So if you or someone you know needs immediate help, please contact the National Suicide Prevention Lifeline or the Crisis Text Line. If you have not heard already, the National Suicide Prevention Lifeline recently put out the short 988 number that both numbers still work. It's an easier number to remember and to reach out using, and they will try to connect you with a local individual to talk to and local resources as well. Again, I'm Jessica Bunting. Here's my email address. As I mentioned, feel free to reach out to me, and even if your question's not for me, I'm happy to direct it to the right person. So again, just really quickly going over why do we need to address mental health in the construction workplace. The fact that you're on this webinar means that you probably have some idea, but in 2017, there was a 40% rate increase of all working age people, and that's in less than 20 years. The suicide rate is clearly rising across the US, but construction workers, especially particularly male construction workers, are at a greater risk of suicide than the average worker. And this is across the board at all levels, so laborers, skilled trades operators, as well as management. Male construction workers have a suicide rate that is 65% higher than all US male workers. Looking at that a different way, so this is broken down by major occupation group, and you can see that construction and extraction are at the top with a rate of 49.4 per 100,000 workers. This is not all of the options broken out. There are more major occupation groups, but these are the top ones, and I wanted to demonstrate that construction and extraction are at the very top, even ahead of some others that you might expect. Looking at it a different way, just at mental health in general, we know that 1 in 5 adults will experience mental illness, with almost 7% experiencing depression and 18% anxiety. That's 52.9 million people, and 60% are left untreated. This is not only disruptive to their own lives and the lives of their loved ones, but it's disruptive to their work as well. And so, depression also presents dangers for injuring yourself further. Not related to suicide, just, in the workplace. It's the first leading cause of disability. It also increases the risk for other chronic medical conditions. And mental nervous conditions are ranked number 3 of all disability claims. So we all have an interest in protecting our workers here. I also wanted to just briefly touch on the impact of COVID-19. We have a whole data bulletin on this, which my colleague Chris Rodman will mention later, but we know COVID had an impact on everyone, across the country, but it's also seen in construction, of course. So what are the construction risk factors? I threw up a slide here on Joyner's interpersonal psychological theory of suicidal behavior, proposed in 2005, that says an individual will not die by suicide unless he or she has both the desire to die by suicide and the ability to do so. And so taking this chart and thinking through what would fit in some of these circles here: perceived burdensomeness, lower thwarted belongingness, and acquired capacity for construction workers. We can see the breakdown here, things that may cause perceived burdensomeness, chronic pain, a skills gap or feeling stuck, promotion of supervisors without leadership training. Lack of belongingness could come from the stoic mentality in the construction industry, feeling separation or isolation, layoffs and financial instability. The capacity for suicide, you have access to lethal means on many job sites. There are veterans in the workforce, and alcohol and substance use disorder, as you will hear later, can often play a role. And of course, additional factors, men are more affected by this suicide epidemic in general, sleep disruption, deprivation, and poor access to and utilization of behavioral health care. I would just say healthcare in general here, not even just behavioral. All right. Oh, I thought I had another slide, but I moved it to the end. So with that, I'm actually going to pass it over to John to give us some more background and information about how you can help loved ones and recognize the signs and symptoms. John,
thank you, Jessica.
Giving you
thank you, Jessica. Appreciate that. I'm going to go through what I consider my personal journey with regards to this topic of mental health, especially suicide. My contact information is there as well. So if you need to reach out to me, please do so. So the first slide I want to cover is something that was just about a month ago in the Wall Street Journal, and I called it the State of the Nation. And it really is dealing with the serious mental illness in the past year among U.S. adults. And the reason I really wanted to point this out is because we have so many of our construction trades and contractors out there trying to recruit. And that's the point of the slide to me, is that area that is identified with the arrow, the 18 to 25-year-olds. That's our future in this industry of construction. And with that being said, we can see in the general population there's a spike with regards to mental health issues in the past year. And then we also have data from CPWR showing us that there was a jump in the 18 to 25-year age range as well. These people are 5 times as likely to report serious mental distress issues, and twice as likely to report suicidal ideation than those of their peers 50 years and older on the job site. So it's something that I think is worth mentioning, because it kind of sets the stage as we dig deeper into the stats. This slide here comes from the International Foundation Employee Benefit Plans for about the last 12 years or so. Every 2 years, they do a survey. This one was of apprenticeship directors and coordinators in the United States and Canada. And there were about a little over 130 participants in the United States, and a little over 35, I believe, in Canada. So these responses are the trainer's perception of their student body, of what's going on with their apprentices. And if you look at the circles here in each one of these categories, circle with the light blue is the responses from the U.S. Training directors and coordinators, and the circle with the red in it, segment in it, those are the Canadian responses. And you can see some of the issues that Jessica just covered, such as sleep deprivation. In Canada, those coordinators, over a third of them, felt that that was an issue that they needed to be concerned about with regards to their apprentices. And you can go on through and see, to the far right on the upper portion, over half of the U.S. Coordinators were concerned about drug abuse and or addiction with their apprentices. But let's really focus on the lower half of this chart. Reading it from left to right, we can see that when it comes to anxiety, over a third of the U.S. coordinators are concerned, whereas over 2/3 in Canada, they were concerned about their apprentices with regards to anxiety issues. Over a third in the United States versus over a half with regards to depression. And then just over 20% with regards to the United States regarding suicide, and almost a quarter in Canada. And so if you read that chart at the bottom from left to right, I think one of the important things here is to remember that anxiety often leads to depression, and depression sometimes leads to suicide. So these are things that we really, as people in the construction industry, have to take to heart and be concerned with. And this furthers my point with regards to white and blue collar workers in the construction industry. This is from the CDC. It's a snapshot back in 2016, showing us the 32 states that they collected data on. And these are the suicide rates for the male population in these various trades. And we can see iron workers rank at the top, and this is per 100,000. One of the points I want to bring out to you is that you'll notice that these are not all just blue collar trades. You can see just a little bit below halfway down that we have construction managers at about 46 per 100,000. And I guess the thing you really want to use as a benchmark is at the very bottom is all occupations, noting that and when it comes to all occupation, the suicide rate for males is about 27 per 100,000. So once again, you can see that we're over the average, and each one of these areas, whether it's blue collar or white collar, should again take this in consideration in their work going forward. So getting more specific to my own personal journey, I would have to say that my work in mental health aspects started back actually in the early 2000s. Washington University School of Medicine, Dr. Anne-Marie Dale and Dr. Pat Evanoff came to me and said, hey, we would really like to begin working with your apprenticeship program on aspects of safety so that we can measure what's going on, how your training is impacting your apprentices and journey level workers. And so we started with the low hanging fruit. We were studying the physical aspects of safety, trips and falls and things of that nature. And then before we knew it, 07, 08 come rolling around, and it's a Great Recession. And I could actually see it in our apprentices. Their demeanor, their physical demeanor was just, it was just wearing on them what was going on out in the field and at home and in their community, where they were used to back in 04, 05, working 60, 70 hours a week. Now they were barely scraping by on 25 hours a week. And of course, every 3 months when they came to school, I would pull some aside and talk to them. And it was just, it was an awakening moment for me, because people were telling me at one point, maybe in the fall, that they had just lost their truck, and then I see them in the winter in a training session, and they had just lost their home, and then I'd see them the following spring, and they had just lost their family and marriage and all that. So I went back to our researchers at Washington University and asked them if we should not start considering the mental aspects of safety as well. And so that led us into some work with regards to financial literacy for apprentices. This was a softer pathway into this area of mental health. the data just came out just about 2 months ago that it's still about 92% male in the construction industry with regards to the demographic makeup. So this was going to be a tough sell just to walk right in and say, oh, we need to start doing training on mental health. So we kind of backdoored this and we said, what was a common theme when you talk to those apprentices in the fall and the winter and the spring? And it always came down to what seemed like money. And so maybe if we could help them better manage their money, we could approach mental health from a financial literacy standpoint. And not too soon thereafter, then our nation was really, and our industry was really experiencing the opioid crisis. And it really hit home with me when a local labor leader lost his son, his 36-year-old son, to an opioid overdose. And this wasn't just some labor leader. I had known this labor leader since back in high school, back in the mid to late 70s. And so this truly became my aha moment that stigma and silence was probably two of the worst enemies that we had with regards to opioids in our industry. And so he and I went on a crusade and we started to awaken our industry. And believe it or not, a year later, in March of 2017, my family had our own personal experience with suicide. My 24-year-old son had taken his life, and it was a result of head injuries experienced in high school soccer and football. And as this labor leader who had lost his son to opioids a year earlier, and I stepped back and said, goodness, opioids took your son, suicide took my son. We're both in construction. And the data is showing us that depending on what source you went to, the construction industry as an industrial sector was probably number one when it came to opioid abuse, and number two when it came to suicide. So again, we just kind of raised the bar and went after not just opioids in our industry, but suicide as well. And I really want to drill down on this a little bit further because I look back and consider what I was doing the last 10 years of my time in the trade. And I can tell you that most of the apprenticeship programs in St. Louis were spending hundreds of thousands of dollars a year on recruitment. And there are often two targeted populations we went after. We often went after military vets and ex-college and high school football players. And there was a reason for that. We understood that there was a commonality between these two groups. They were used to working out in hot and cold. They understand the chain of command, how to take orders, what a goal was. But I think what we failed to do is not consider that one other common theme. And as most of these people have been exposed to traumatic brain injuries, if you look at the data on what's happened post 9/11, over 500,000 of our military people have been diagnosed with PTSD, and 300,000 of those have been diagnosed with TBIs and things of that nature. So we really have to take that in consideration because this is something that just doesn't happen overnight. And so I have to share with you that it was wonderful to see the AGC of Missouri in 2019 pick up the torch and really move on a suicide prevention task force. And every year they've upped their game since then. And I really appreciate that because it's made it much easier to talk to white collar and blue collar workers about some of these tougher issues with regards to mental health, opioid addiction, and suicide prevention. And then, of course, just a month or so ago, I have to hand it to CPWR. They held a workshop where they brought in about 60 people from across the United States in the construction industry and had what I would call a summit on combating suicide and overdose fatalities with regards to construction workers. And I really do appreciate the work they've done because over those 2 days, we had discussed what's working and what we still need to do. And so we kind of have some marching orders going forward. So the work is by far not done. So to get to the nuts and bolts here, you know, some people will say, okay, that's your story. So what do we do with your story? Well, I would say that you have to look for those warning signs. Because as I mentioned earlier, due to stigma in our culture in the United States, we've been taught since little children that it's impolite to talk about suicide. Well, one thing we know from the research is we are not going to push someone into uh, suicide, contemplating suicide, just by asking them, "Are you thinking about killing yourself?" That's an old wise tale. That's a myth. So let's dig further, a little deeper into this area. So, what are some of the warning signs? Whether it's direct ones, there's indirect ones, and then there's a category known as other. So, direct warning sign: you may hear someone verbally say, "I'm going to kill myself." Or you may notice that in June they had just a bottle of Advil in their lunch pail, but now they got Advil and Oxycontin and some other things. So that's a behavioral direct statement. From an indirect statement, um, you have to consider, someone saying something like, uh, I'm going to, I'm going to be going away forever," or I don't need these anymore, and it might be a prized possession. Um, and so that could be a mixture of behavioral and verbal in the same context. Um, I can give you a little side story here, and a few years back, a tradesperson on a job in Western Missouri went away from break, and as he was going away from break, he took off his pool pouch and handed his pack of cigarettes to another worker, saying, "I'm not going to need these anymore." Went to an upper floor of the building and walked off an unguarded edge. And so we really have to begin to trust our gut. When you see something that doesn't look right, that doesn't look normal, you need to take action. And so, what are some of those other signs? You may hear somebody speaking from a standpoint of hopelessness or rage. They may be angry all the time, or their swings their moods may swing during the day. They may be happy as a lark at 8 o'clock in the morning, and angry at 10 o'clock, and then happy as a lark again at lunch, and so on. So you really have to watch what's going on around you. You might notice that they're increasing their alcohol or drug usage. You may hear them discuss the issue that they haven't had, good sleep in a while. This is a huge issue in our country. It's this whole sleep deprivation thing. So as you can see on there, we know that performance can be also denoted, as warning signs. You might notice that their ability to problem solve has decreased. Well, when you're always on alert, you're thinking from the reptilian brain, the fight, fight, or freeze portion of your brain. And so if you're always on, you're going to be worn out, and it's going to start wearing on your nerves, and that's going to decrease your self confidence. It's probably going to impact your tardiness and absenteeism, not to mention presenteeism, which may be even more dangerous, that you're physically there, but you're not mentally there. So that's not just about a danger to yourself, it's about a danger to your coworkers as well. And you may start seeing them become more irritable and having conflicts with their coworkers and causing injuries or near misses. So moving on, there's a campaign in Australia called "Are You Okay?" And I really like the tagline here because it says a conversation can change a life. So if you do notice someone acting differently and quirky from what you've noticed over the past months or years that you've known this individual, pull them aside and in private, find a nice, compassionate way to ask them, how are you doing? And don't stop it right there, because most people are going to say okay or fine. You got to dig deeper, because you're doing this because your gut's telling you something's wrong. So, two, listen to what they have to say. Allow them to speak to you. It's funny. When I was doing a training a while back, one of the students sent me a note and said, um, there's an acronym for what you're talking about when you're using active listening skills. And that acronym is WAIT, WAIT. And he said, always remember, when you're asking someone an open-ended question, let them pour their heart out to you. And remember that acronym, which stands for why am I talking? So ask that prompting question, let them open up. And you may have to ask some other prompting questions during the time, but let them do the bulk of the talking, so that you can move to step three. Now, remember, if you've got them to say yes, then you now have an obligation. So encourage action. And depending on how that yes came about, that may be immediate action. And I'm a big fan of what I call the warm handoff. Don't just ask them to call their doctor. Why not make sure you're side by side with them until you can hand them off to a mental health professional or their own physician? And then finally, number four, this isn't over. It's not a one and done. We have to continually to check in on this person. And that may be every other day in the first couple of weeks. And that may move to every other week for the first couple of months. And then 3, 4 months out, it may be just once a month. But make sure you show them that you care. The science shows us that if you intervene in someone's suicide plan, that up to 3 months later, 95% of those people are still alive. So if you don't think you make a difference, the data shows differently. So some of you may be saying, so where can I get some of this training? Because I don't feel well prepared to do stuff like this. Well, I can tell you right here, here are 2 links. And as Jess said earlier, this is being recorded and the slides are being pushed out as well. So these 2 links are available. The first one's from CIASP. If you go to their landing page, you will find about a third of the way down this 90-minute program. It's an online interactive program. It's probably the best online interactive training I've been through on suicide prevention. It's free. Please do it. It's worth the time. And the other one, you might be saying, why is John mentioning anything about the ag industry? Because I'm telling you right now, in my sector of the industry, where I come from, the Midwest, I would say upwards of 40% of our members are into farming and ranching on the side. And so AgriSafe has done a great job on doing monthly 1-hour lunch and learn podcasts on these different topics of opioid abuse in the agricultural community, as well as suicide prevention, as well as mental health. And you'll find by going through those, you'll find ways to apply and transfer that knowledge over to your sector. I can assure you, they've done great work, and I wouldn't waste your time talking about these 2 pieces if I didn't think they were important. So what are the action steps? I would say, and these are John Gall's action steps, I would say that we have to begin piloting different types of peer support models, because I don't think any one is going to fit each and every community. So let's look at some of the better ones that are out there that have some data. So Mates in Construction is a program that's been running for about 8 years down in Australia. And it's a peer-to-peer support program specifically for preventing suicide in their construction industry. Another one you may have heard of comes from Leona, the laborers up in Massachusetts. Now, this peer-to-peer program is more specific towards opioid awareness. And that acronym is Laborers Ending Addiction Now. That link you see there is about a 3-minute video. I would strongly suggest you take a look at it. And then finally, again, looking to the international marketplace, there's an organization called the Friendship Bench. And this is out of Zimbabwe, Africa. Again, this is a peer-to-peer model, and it's a very interesting approach. It tends to use the elders in the community to reach out to anyone that needs help. And again, when we're kind of still grasping at straws on what's right, and I don't know that there's any one answer. I think we have to figure it out, but we don't have to reinvent the wheel. We know there are some good models out there. So moving to the second bold topic there, and that is, I think we need to begin embedding mental health in our training programs. And again, let's turn to the international marketplace. If you're familiar with the International Standards Organization, they have a standard called 45003. This is a standard that deals with mental health and worker wellness in the workplace. It is a pretty much what I would call the gold standard. And I think that it would behoove us to become more familiar with these types of international standards and set our sights that high that we can do these things in the United States as well. And before I leave this area, I want to touch on something that, if you know me, you've heard me talk about this with regards to embedding mental health training. I think we are here today where we were 20 years ago with OSHA 10. I can remember 20 years ago when the owners, the buyers of construction came to the contractors, and the union said, no one's going to be on my job site, no one, unless they have an OSHA 10 card in their pocket. And where did most of the contractors and unions turn? They turned to the training schools. And so I would say we need to have an effort to start embedding at least a 1-hour mental health type training into at the very least, our pre-apprenticeship programs, and moving that concept farther on throughout the stages of apprenticeship. Because this isn't a one and done. This isn't something we do early on in apprenticeship when we never talk about it again. Again, leaning back to the OSHA 10 concept, a lot of us who just did the OSHA 10 at first realized after a short period of time, goodness, whether I'm building a wall or framing a roof, there's safety aspects in both of those. And we need to pull them out of that OSHA 10 course and reinstitute those into all these other training aspects that we do. And so that it looked like it was an effort that was more than something done in a silo. And I think that's why it's so important. We've tackled the physical aspects of safety. Now it's time for us to do the same. And in 5-6 years from now, we could be at the same point we were 15 years ago with OSHA 10. And then finally, as the director of worker wellness for the Missouri Works Initiative, I do put out a weekly blog on wellness and well-being, and that's the link to it. And that's updated every week. So it deals with aspects of mental health, opioid abuse, and as well as issues of suicide prevention. So that's my piece, and I'm going to now turn it over to Karina. Thank you very much.
Thanks, John. I'm Karina Lorick. I'm the area director of the Kansas City Area OSHA office. September 5th through 9th is Construction Suicide Prevention Week. OSHA's mission is to ensure that workers go home to their families alive and well. OSHA is committed to supporting the mental health of America's workers. So here's a little message from OSHA's Assistant Secretary, Douglas Parker, about suicide.
Hello, I'm Doug Parker, Assistant Secretary of Labor for Occupational Safety and Health. I want to talk to you about a critically important topic, suicide. Suicide is a leading cause of death among working age adults in the United States. It deeply impacts workers, families, and communities. In 2020, more than 45,000 Americans died from suicide. That same year, there were 1.2 million suicide attempts. According to the National Institute of Mental Health, nearly 1 in 5 adults live with a mental condition, such as anxiety, depression, or post-traumatic stress. There is no single cause for suicide, but we know that work-related stress and work-related medical conditions can significantly impact mental health and lead to increased risk of substance abuse or even suicide. Because of this, we see much higher rates of suicide in some industries than in others. Construction is one of those industries. The rate of suicide for construction workers is 4 times higher than the general population. Work-related stress from seasonal or inconsistent work, demanding schedules, and work-related injuries are all risk factors that could lead to suicidal thoughts. Mental health and suicide may be difficult to talk about, especially with work colleagues, but you are not alone. If you are having trouble coping with work-related stress, or if anything is giving you a feeling of hopelessness and you are having suicidal thoughts, it is critical that you get help now. Call or text the Suicide and Crisis Lifeline at 988, or join the chat online at 988lifeline.org/chat. When you work closely with someone, you may sense when something is wrong. If you are concerned about a coworker, talk with them privately and listen without judgment. If you believe a coworker is in immediate risk of suicide, stay with them until you can get further help. Contact emergency services or call 988 for the Suicide and Crisis Lifeline. If you are an employer, show your workers that you care about their overall health and safety, including their mental well-being. Promote mental health awareness and eliminate barriers to getting help. Suicides are preventable. Visit the American Foundation for Suicide Prevention, www.afsp.org, to learn more about suicide risk factors, warning signs, and what you can do to help prevent suicide. Mental health is part of overall health. That is why the U.S. Department of Labor and OSHA are deeply committed to supporting the mental health of all workers, just as we are committed to protecting them from physical hazards on the job. We are proud to join with the many individuals and organizations across the country to recognize September as Suicide Prevention Month, the week of September 5th through 9th as Construction Suicide Prevention Week. I want to thank OSHA's Kansas City Regional Office and their partners for their work on this important topic. It is truly life-saving. And thank you all for being part of this effort to prevent suicide.
Okay, so suicide is the leading cause of death among working age adults in the United States. So why are we focused on construction? Construction has one of the highest rates of suicide among all occupations. It's 4 times higher than the general population. Construction work-related factors may include the inconsistent or seasonal work, demanding schedules, and workplace injuries that are sometimes treated with opioids. The industry's tough guy culture can also make it hard to ask for help or support. So here's a brief background of how all of this began in OSHA. In 2019, the St. Louis area office, along with the Associated General Contractors of Missouri, Washington University, and the University of Iowa, developed toolbox talks, coins, and started having those difficult conversations on mental health and suicide awareness with construction companies and workers to help reduce the stigma of suicide in the construction industry. Also in 2019, after several suicides in the local Kansas City area within construction, the Kansas City area office and the Builders Association, another OSHA partner, worked with the construction companies, American Foundation of Suicide Prevention, and unions to develop a construction suicide prevention stand-down to remove the stigma of suicide and provide education in order to save workers' lives. Each year since, the construction suicide prevention stand down has grown with registered participants and participating states. Last year, the stand down had over 65,000 participants that were registered. As of Tuesday of this week, this year's stand down has had over 165,000 registered participants nationwide. In 2021, Region 7, which includes Missouri, signed the Healthier Workplace Alliance with the University of Iowa, focusing on behavioral health, including suicides and opioids. Since 2018, Region 1, which is out of Boston, has had a very successful regional alliance with the American Foundation of Suicide Prevention. Region 1's alliance was the foundation for the national alliance that was signed between OSHA and the American Foundation of Suicide Prevention. That national alliance was signed on Wednesday, September 7th. These efforts were combined with tremendous support from OSHA's national office, all working towards common goals. Bring awareness and information on how to prevent suicides in the workplace, remove the stigma and provide education to save lives in the construction industry, and educate OSHA's partners, stakeholders, associations, and unions, and federal agencies on how to initiate those difficult conversations and to keep mental health awareness year-round. OSHA has also developed a 5 Things You Should Know poster. Step 1 is be aware. You spend more time with your coworkers than you do at home with your own family. You know their behaviors, you know their moods, and you know their mood changes. Know those warning signs. John went over some of those warning signs. Could be changes in mood, behavior, giving away those possessions, or are they talking about suicide? Reach out, ask, are you okay? And don't just take that first answer of, yeah, I'm fine. Ask it again. You could save a life. And take that action. If they're at immediate risk or believe they're at immediate risk, stay with them. Call emergency services yourself, call 988, and call, text, or chat 988, which is the National Suicide Lifeline. They will walk you through and get that person help. And you can always learn more about suicide prevention resources. OSHA has a webpage on osha.gov/suicide, preventing suicide, has PSAs on suicide prevention and that 5 Things You Should Know. And there's additional mental health and suicide prevention resources from other agencies as well. So last year, I'm going to tell a little story. So last year, I learned about a worker who attended a construction suicide prevention that was hosted by his employer in 2020. 6 months later, that employee called his supervisor and told him he was actively deciding to take his own life. He was on the side of the road and debating when he was going to take his own life. The supervisor found out where that employee was located, went to the employee, called 911 to get emergency services out there. Then he took the additional step. He called the National Lifeline. And that National Suicide Lifeline was able to get the employee help and get him into a facility in order to get him help. That employee is alive today because he knew it was okay to ask for help, and his supervisor knew what to do. This week, I spoke at a stand down, and I told this exact same story. After the stand down was over, an employee came up to me and asked to speak with me. He told me he was the employee in the story, and he is alive today because he knew what to do. He knew it was okay to ask for help, which is the most important thing. Remember, if you or someone you know is having thoughts of suicide, please call, text, or chat 988. It's manned 24 hours a day, 7 days a week. 988 has trained crisis counselors. They answer the phone, they will listen to you and provide that support, and they provide that help, just like that gentleman in the previous story. Please join OSHA and myself, and along with our numerous partners, in order to reduce and prevent suicides. Thank you. And I'm going to pass it over to Chris.
All right, thanks, Karina. Thanks, everyone. My name is Christopher Rodman. I'm the CPWR Opioids Projects Coordinator. I will mention a few things about opioids, and that's how CPWR has, I'll talk a little bit about CPWR's journey in starting to deal with this issue. I was too optimistic about how much I could get through in 15 minutes, so my apologies. I will be skipping some slides and pretty much going to our resources page. But one thing I wanted to point out before I do that is that CPWR is the nonprofit arm of NABTU, North America's Building Trades Unions. And a few years ago, NABTU passed a resolution at their annual conference, or I should say conference that happens once every 5 years. And that resolution stated that NABTU wanted to support efforts to reduce pain, opioid use, opioid overdose, and the number of deaths by suicide in the construction industry. So CPWR took this along with our work with the NABTU Opioid Task Force, which was established in 2018 by NABTU President Sean McGarvey. And we took that and we wanted to move forward and work to not only be working with opioids, but to now include working with suicide. It's worth noting that we think that these things are, of course, linked. Opioids, there is a recent study that came out in Utah that working age men, 1 in 5 working age men who took their life in Utah over the 10 years, 11 years from 2005 to 2015, who worked in construction and extraction, had, of course, the highest rate of suicide in the state. But the thing that was most interesting to us also was that a quarter of those who tested positive, or I should say a quarter of those in the last 2 years did in fact test positive for an opioid. So we think these things are related. We don't exactly know how. John alluded to the fact that we're kind of scraping the surface in some of these things and just starting to learn more and more. But we know these are related, and so we still want to be focusing on both. I'm going to skip that. Everyone else has talked in a great length about some of these statistics, but I'm going to mention our opioid awareness training. This is something that we started a few years ago, and it was done on behalf of NABTU. Originally, our opioid awareness training had an opioids awareness section and a mental health training. When we piloted this, we separated it into 2 separate trainings. You can currently find the opioid awareness training on our website, and we are finishing up a pilot of a mental health training that includes 2 modules that are particular to suicide, and I'll share a little bit more about that at the end. CPWR has a paper that you can find on our website about peer advocacy in the construction industry. Look at my notes here, thank you. This was something that we were able to interview people from the NABTU Opioid Task Force to learn about how they had responded to the opioid crisis in construction. And it turned out that 7 of the 13 interviewees who we discussed had a peer advocacy program. And of course, this is a program where they can be different from union to union, but for the most part, this will be a peer who is on site, who is designated as someone who someone can come and talk to if they have an issue. Peers can be someone who you can talk to about opioids, about suicide, mental health, and this comes from models within the medical industry, and most recently it's being used in Australia, which was mentioned by John. So let's talk about some things you can find on the CPWR website. The data center has put out some bulletins, and there is a dashboard that you can look at. The bulletin that was released explored some of the increases in overdose deaths, opioid use patterns, and the mental health symptoms reporting, essentially things we're reporting before and after the COVID-19 epidemic. We know that, workers who were surveyed early and then into the pandemic showed a 43% increase of the frequency or level of anxious or depressed feelings. And we know, of course, that those can be related to worse things like having a substance use disorder or suicide. I think one of the things that is really important to point out is that when we start to talk about these issues and make this conversation about suicide prevention more normalized, what we're doing is we're starting to reduce the stigma of these issues. A lot of people are not comfortable reaching out for help because of how stigmatized this issue is. And so having things like the suicide hazard alert around a job site or posters we'll show later, that can be very important to show a worker that they're in an environment where they can go to those around them for help. Both our hazard alert and our toolbox talk refer to a framework that was created along with CIASP, the Construction Industry Alliance for Suicide Prevention, and that is reach out, respond, and connect. Reaching out is asking that question to someone about whether or not they are thinking about suicide. You've learned a lot about some of the signs that you might be witnessing if you see changes in someone's behaviors, that you might feel that you have to do something. And the research shows that that question should be asked, and it should be asked very directly. John already said you're not going to make someone think about this who is you're never going to make someone go further along who's already thinking about it. The research shows that most likely people are going to be relieved that they finally have someone who is willing to talk to them, and that they know they have an advocate. So this is two different ways of doing it. The toolbox talk essentially tells a story that can be discussed among workers, and the hazard alert can be shown on site. The two posters on the left are more posters that can be put up on site. These have to do with suicide, and the ones on the right are for opioid deaths. Thanks, John. And same thing with these toolbox talks and hazard alert. The hazard alert could be found around on site. Please go to our site, our website, and download. We'd be happy to have people using these. And then the toolbox talk tells a story, so it can be, the story can be discussed in a short format toolbox talk. Again, we know that these things are related. So one of the things that I wanted to point out is that we have a physician's hazard alert, that someone who has an injury, who maybe need to be seeing a physician, can bring this to their physician, and it can help facilitate a conversation between that worker and the physician to say, I'm looking for an alternative to opioids in this treatment. We know that anyone who has exposure to opioids has a risk of becoming addicted, and we very much want to stop people from having that first prescription. This is one of the ways to do that. Thanks to everyone for being here today. I'm going to talk very quickly about our current efforts. One is the mental health module activities that I mentioned before. Two of these have to do with suicide, but this is to be done in a discussion-based setting. This is not didactic classroom PowerPoint. Much different. This is for small groups with a facilitator. And when we were researching it, we found that this was going to be the best way to, in fact, instill the behaviors that we're trying to teach. If we're trying to teach someone to have that reach out, respond, connect conversation, it can't necessarily be done the way we're doing it today. It's not necessarily helpful for you as a participant. But when you're in a small group and you're practicing and you're saying the words, that's when the rubber meets the road with the learning. So that's why our new mental health pilots are this way. And we hope those will be on our website within a few months. Secondly, we're working on a bullying prevalence survey. We're currently working with one of the international unions to facilitate this. But the reason we came up with this survey is we know that Workplace bullying is associated with increased suicidal ideation and increased risk of depressive symptoms. We also know that apprentices are the most likely target of workplace bullying, and that, of course, gives me, puts a star on that slide that John shared in the beginning, showing that we now have an increase in the prevalence for the younger segment of the construction worker population. So we've partnered with the union and Contractors Association and Apprenticeship Training Center, and essentially there's a Department of Labor. I'm just missing the word here. There's a requirement for a harassment curriculum, and this is going to help. This is going to help people evaluate that curriculum. Finally, John mentioned the workshop that CPWR facilitated about a month ago. This workshop had kind of three main objectives. We were going to map the organizations that were focused on preventing opioid overdoses and suicides in construction, and then think about the relationships between them. Second, we wanted to identify opportunities for innovation, collaboration, and increased investment. We know that many people are working on these issues, but they're doing it in their own silos. So our goal was to get people together and then create working groups so that people who have, who are like-minded but working separately can come together and be working together in the future on these topics. The workshop allowed the attendees to do some co-creation and get it down to some topics that people were interested in collaborating on together. And then the attendees split out into the top 4 of these group topics, which were training and education, changing the culture and stigma reduction, injury prevention and workplace stress, and then peer support. And the goal is that each one of these topic groups is going to be meeting quarterly or more for the next few years to make sure that these people, again, who are working separately but for the same purpose, are now going to be working together and collaboratively. So we're asking these groups to think about some of these questions as they work together in the future, and that is, what are some of the research gaps? What are some things we need to measure? What are some things that we, and then within those measurements, what are some common indicators? We think that the research can help focus the problem and help find some of the most impactful solutions. We know that maybe it's what's working for one group may not be working for another, but the goal is essentially that if there are some things that people are measuring, but and doing so in separate places, that it's going to help facilitate that collaboration, because that'll be one of the reasons to get back together and to talk about how things are changing. CPWR is writing a white paper that pertains to this workshop, and you can probably find it on our website shortly. But essentially, these groups will be meeting, CPWR will be tracking this, and we'll be sharing the progress. So thanks very much. That's the end of my spot here. I see we're getting very close to the end, and so I'll hand it back to Jess. Thank you.
Thanks, Chris, and thanks to everyone on our panel. We are right at the end of the hour right now, but I still see a couple hundred people are online. So let's go ahead and try to take a few questions. I actually am going to touch on this slide that I stuck at the end as an extra slide because I think it gets at one of the questions that came in through the chat, which is that I'm hoping to hear from panelists with recommendations or resources for employers who do not have direct connections to the employees. So for larger companies, with contracted workers, with general contractors working with subcontractors, those types of things. And I just want to mention the concept of creating a caring culture and how that can positively impact a company. This slide has just a few ideas, more than a few. It has ideas of what that would look like and what actions could be taken by companies to better support the mental health of not only their direct employees, but any subcontractors and contracted employees as well. And that includes things like leadership support and encouragement. We find that that's really just an important factor for safety and health in general, not only mental health, but any good safety and health program is going to have leadership and management involvement. You also want to have injury management programs, return to work plans, and alternative pain management programs. Preemptively working on things like ergonomics, manual materials handling, addressing those types of issues to minimize pain is always a good idea. So I'm not going to go over all of these, but this is in the slides that we shared, and I just did want to touch on that. In response to the question, I also wanted to mention we have some additional resources slides. These are the webinars that CPWR has done in the past that I mentioned in the very beginning. And then these are just additional resources from all four of us that weren't included elsewhere in the slides. And with that, I'm going to move to what I think we all felt was a very important question that came in during registration. And that's how do I refrain or delete suicidal ideation on my mind when things aren't going well on my side? Karina, did you want to take that?
Sure. I think the most important, I mean, this is a very, very important question. This is why we're here. It's whoever asked that question, you're asking for help. So in taking that next step farther, call, text, or chat 988. When this question came in, I actually contacted the American Foundation of Suicide Prevention because they're the experts. I'm not a mental health expert. So I wanted to make sure I was giving the correct information. And they pointed me directly back to contacting 988 and that you're taking that first step and in asking for help and reach out to someone directly, personally, and say, I need help. And they will get you help.
Thank you. Yeah. All right. Another question that we got in advance is, how do we as training directors or instructors with limited training in mental health or psychiatry deal with students that may be dangerous? And Chris Rodman, I think you had a response to that one.
Oh, I think it's kind of an extension of what Karina was saying, that you're right. We are not mental health professionals, and we need to be we need to be using the resources that are available to us. You know, John showed a few different resources. A way to there's the Living Works teaches you how to have a conversation with someone who is thinking about suicide. That's a really great one because it's like John said, it's free, or it certainly was free when I took it. I don't know if it has a paywall now, but there are some great videos on there. They show examples. They make it very simple, and they kind of have you practice how to do it. And I think someone would be comfortable having that conversation after seeing Living Works. But the main thing that they do reiterate is that you're not a professional, and what you're doing is making sure that you're that soft contact to get them to a resource. And depending on where you are in the country, there might be different resources that could be, you know, local to you. You might have an MAP that you could get someone off to. But if it is truly, you know, an emergency, or someone, you know, with active thoughts of suicide, getting them to that 988 number is going to be the best first bet.
Jessica, this is John. Having been a former training director myself, I would suggest that you know, knowledge is power in this area. Again, as Chris said, we're not going to be mental health professionals, but we can be advocates. And one step in the right direction of becoming an advocate is getting trained up in some of these areas. And I would strongly recommend people, as Chris just said, going through the Living Works. I would also highly recommend that they seek out the QPR training in their region. It's about a 1 hour training session on suicide prevention. It stands for question, persuade, refer. In fact, you can get that free online through that AgriSafe link that I gave you. They do that recently. They've been doing it once a month. So again, those are the first couple of steps. And I think this is going to have to be tiered. Just like in the OSHA 10 model, we first said everybody had to have an OSHA 10. And then what we realized later on was, you know what? There are people on the job site, not everybody, but a select few that need just a little bit more information. So then we went to the OSHA 30 for foremen and superintendents and so on and so forth. And I see this being, a route for us to go. We could start out with these 1 hour types of training programs, but certainly move eventually into programs such as a mental health first aid course, which is 8 hours. But that's a lot to take in for someone that's new to this topic. And the one thing we don't want to do is turn people off right away. We want to make them advocates as well. So I appreciate the opportunity to share that.
Yeah, that's good advice. Thank you. I have another question that John, you might want to take a stab at, and that's, given the significance of mental health as an emerging hazard, do you see any place for it in the pre-task job hazard analysis, JHA? And if so, how should it be implemented?
Well, I think I'm going to come from this possibly from a little bit different direction, and some people may not like my response to this, but again, with the OSHA 10 effort, where did that begin? That started with the owners, the buyers of construction, saying this is going to be done on my job site. So he who holds the gold makes the rules. And if we see these kinds of issues being written into the contract documents, I think it's going to be better for everyone, because it levels the playing field, and it forces all the players into the arena to take an active part. And so I'll give you an example. I was doing a live person presentation about a year ago, and someone came up to me afterwards, and she told me that she has her own safety consulting firm, and on more and more jobs, she is now being required by a mental health professional no less than 2 days a week, no less than 6 hours a day. And the GC, the general contractor, has to supply the private space for that person to operate out of. So when that's written into the contract documents, it levels the playing field for everybody in the game. And so that's how I would approach it. Till then, again, I think you have to, if you're going to be an advocate, you're probably already going to be on the leading edge. And so, with that being said, you're going to school yourself up on these issues and push the agenda. No one said leadership was easy. So being a leader, sometimes you're gonna take some cheap shots. People are going to take cheap shots at you. But let me tell you, in 2016, when that other labor leader and I came forward on the opioid issue, we weren't well liked at the very beginning. In fact, a number of the GCs in this area were being advised by their legal staff not to touch that issue with the 10-foot pole. So, but the facts are the facts. We were having people actually overdosing in their cars at lunchtime, found with needles in their arm. This isn't a made up story. I know this for a fact, firsthand. So, I guess until the crisis hits your own dining room table, it's not a crisis. And that's the sad thing. in order to be a leader, you have to be a visionary. And sometimes you have to take the good with the bad when you do these kinds of things.
Sorry, I was muted and minimized, looking at the list of questions. Thank you for that. And I think we've answered most of these, but I do want to ask one more, and that's, do you think mandatory pre-employment substance abuse testing is a positive action to encourage people with substance use disorder to seek assistance to protect their livelihood? Any thoughts on that? Oh, now you're on mute, John.
Sorry, say that again, please.
The question is mandatory pre-employment substance abuse testing a positive action to encourage people with substance use disorder to seek assistance to protect their livelihood?
Well, again, going back to my days as a training director, I can share with you when we started a pre-apprenticeship program in 2013, 14, we had to sit down and say, if we're going to use yesterday's rules going forward, we're not going to change the landscape here. And in order to change the landscape, you have to look at what's feasible. And we said, if this is a 6-week pre-apprenticeship program and people test positive on day 1, typically what we do in most of our apprenticeship programs, we kick them right out. But we're trying to be in a welcoming culture. So what we did was we found means for them to get help during those 6 weeks. Until this day, whatever that is, 8 years later, we have still never graduated a class that isn't 100% negative. So we gave them time to find the help they needed. And I think I think we're going to have to look at some of our policies and procedures so that we can be a more welcoming environment.
That's great advice. Thanks, John. And all right, I think we're officially 15 minutes over, so I'm going to go ahead and wrap up. Thank you to all of you that stayed on the line for Q&A. And again, I'll just reiterate that the recording and the slides will be sent out. If you have any questions that you'd like to follow up with us directly on, please don't hesitate to reach out. And Karina, John, and Chris, thank you so much for joining and giving such great presentations today.
Thank you for the opportunity.
Thank you.
Take care, everyone.
Much appreciated.
Thanks.